My name is Ryan Shields, and I am the Associate Director of the Moore Center for the Prevention of Child Sexual Abuse. Thank you so much for coming back and joining us. I am so very pleased to introduce our next speaker, Dr. Jill Levenson. Dr. Levenson is currently a professor of social work at Barry University in Miami, Florida. And Jill is also a licensed clinical social worker with over 25 years of experience with interpersonal violence and trauma-related disorders. She's worked with survivors, offenders, and family members of those who have experienced child sexual abuse and maltreatment. She received her bachelor's in sociology from University of Pittsburgh, her master's in social work from University of Maryland, and her PhD in social welfare from Florida International University. Jill's primary area of research, Jill is a noted scholar in her field, so I'm really excited for her to be here. And she studies the impact and effectiveness of social policies and therapeutic interventions that are centered around sexual violence. And her recent work focuses on adverse childhood experiences and their influences on mental health and physical health and criminal justice outcomes. She's published over 100 peer-reviewed articles and book chapters, and she's also co-authored 3 books related to the treatment of sex offenders and their families. And on a personal note, I met Jill during my first year as a doctoral student at Florida State University when she hired me as a summer research assistant. And we have been friends and colleagues since. And when I first met Jill, it was very easy to see that she embodied this dedication to research, but also a compassion in her work. And those are values that I strive to embody in my own work, and that I see demonstrated in all of you here today. And that's really exciting to be around people who embody those values. And not incidentally, Jill also introduced me to Elizabeth, which is an introduction that happened to change my career and my life. So I hope this introduction, we're kind of even now, I guess. Please welcome Dr. Jill Levenson.
Thank you, Ryan. Kind of feel a little bit like a proud parent, you know. I got to watch him be born and grow as a researcher, and Elizabeth, you're lucky to have him now. And congratulations on your new gig in a few months. Thank you. So when they told me I had to talk for only 25 minutes, I thought maybe they had confused me with Elizabeth Letourneau doing a TED Talk. Hard to do. So I'm going to talk to you today a little bit about some of the research I've done around early childhood adversity and its relationship with adult criminality and in particular sexual offending. As you probably know, not only is it Child Abuse Awareness and Prevention Month, it is also Sexual Assault Awareness Month in April, so the timing of this is perfect, probably not coincidental. And, you know, anytime I do a talk like this, I feel like I have to give this warning, although I can tell that today I'm in with kindred spirits, so maybe that's a little bit less so today. But we're going to try and think out of the box a little bit today and get away from some of the myths that many of us have endorsed over the years before we knew better, and to try and think a little bit more broad-mindedly about offending and prevention and how they fit together and what that all means. So nothing I say this morning is intended to diminish the pain or suffering of victims, to make excuses for sexual victimization, or to defend people who do this. But rather, I think it's important for us to try and have a better understanding of how these kinds of behaviors develop across the lifespan and the factors that contribute to them and maintain them, so that we can inform our prevention opportunities better. So, for those of you who may work primarily with victims or survivors, and others who may work with people who have caused sexual harm, I think it is important for us to remember and to get the message out to policymakers that we're all on the same side. There are no different sides here. It's not a contest. We all want the same things, and we need to work together. And so in my mind, that's really the first step in prevention, is to cross that us and them divide, and to remember that we really are all on the same side and two sides of the same coin. So I know that most people in this room are familiar with the public health model of primary prevention and as it applies here for our topic today of child sexual abuse. And this is a graphic from the CDC showing some of their ideas about sexual assault prevention. But what's missing here? Well, perpetrator prevention. So as Dr. McCarthy pointed out, of course, many of our prevention programs have really focused on what victims, potential victims, can do to protect themselves. And that is kind of a backwards message because it's like, well, if something happens to you, maybe you didn't protect yourself well enough. But I think what's missing also from the model is thinking about earlier interventions to prevent perpetration, not just becoming a victim. So that's what I'm going to talk about today. And so when we think about the public health model and what it means, ideally, it should be that we spend most of our resources on kind of what might be called universal precautions, like vaccinations, where we are investing most of our resources to reach the most people and to prevent problems from even emerging or happening in the first place. Secondary prevention efforts are really targeted more toward at-risk populations. So there may be certain people who are more likely to have a specific kind of problem, and we can target them. And tertiary preventions are interventions after the fact, usually when a problem has already presented itself, and then how are we going to try and solve the problem and implement solutions. And you know, what happens with child sexual abuse prevention is that the pyramid really is inverted. We spend the vast majority of our resources on tertiary prevention. When children are abused, we intervene after the fact. We remove them from their homes. We place them in foster care. When kids commit crimes, we put them in delinquency programs. We incarcerate people. We don't even have to talk about that. Sex offender registries are enormously expensive public policies. And that's where most of our resources go. We do have some secondary prevention programs for at-risk kids and families, and you know, I think that in theory we want to try and facilitate better family functioning and parenting, but those are always the first kinds of programs to get cut when budget time comes around, usually in the spring. And we do much, much less primary prevention, which could involve cultural messaging, trying to change the dialogue around sexual assault and sexual violence, and reducing social problems and reducing early adversity for kids that you know, pave the way and plant the seeds for problems later in life. And that's really the piece I'm going to talk about today. I think that we are in an era where we have to wonder what the messaging is and how that messaging gets translated to boys and teens and young people and young men. You may be aware of the ACE study. Who has heard of the ACE study? Okay, great. So in the early 90s, the CDC partnered with Kaiser Permanente, which is a health maintenance organization, and they wanted to try and study and understand the the prevalence of different kinds of early adversities and family dysfunction. And the impetus for this, as I understand it, is that they were beginning to study the obesity epidemic in the early 80s, and you know, kind of realized that as they were taking medical histories from patients, many of the people who had obesity problems and other health-related problems connected to that also tended to have histories of child maltreatment, in particular sexual abuse. And so they kind of set out on this wide-scale process to try and understand the prevalence of these types of events in childhood. And so they collected data from 17,000 patients who were receiving health care through Kaiser Permanente. And what they found was actually surprising in the sense that these numbers were higher than anybody might have guessed or realized. They asked questions about 5 different types of child maltreatment: emotional, physical, and sexual abuse, and emotional and physical neglect, and then 5 types of what they called household dysfunction. Domestic violence, growing up in a home with domestic violence, or with adults or household members who abused substances or who were mentally ill, growing up in a family where the parents were separated, divorced, or where there was an absent parent, I think was more the idea they were trying to capture there, and growing up in a household where people had been arrested, jailed, or incarcerated. And so, here's what we learned about the prevalence of these kinds of experiences in the general population. And so this was very, very informative. Here is the distribution of ACE scores. So there were 10 different items, and your ACE score can range from 0 to 10. And it kind of captures the multiplicity of different kinds of experiences. It's limited. It can't capture the severity. If an event happened once, it still counts as a point. So, but what we know is that only about a little bit more than a third of people said, nope, none of those things ever happened to me. And that would be somebody with a score of 0. And 12.5%, so 1 in 8 people, endorsed at least 4 different items. So the scope of what we were looking at in terms of the portion of the population who had experienced at least one adverse event in their childhood, and 12.5% of people experiencing 4 or more. So we're talking about maybe chronic and continuing adversity in the life of a child. It's also important to remember that these were people who had had health insurance. They were getting health services through a health insurance company. And so it's not representative of the general population. And we know that ACE scores are much higher in clinical, criminal, and marginalized populations. So what we learned about the scope of adversity through the ACE study was enlightening, but it's really not even the tip of the iceberg. The problem is much, much more profound than that. We also know from some of this early ACE research that these experiences rarely happen in isolation. So if you've experienced one ACE item, the odds go up that you will have also experienced others. And so when we're talking about high ACE scores, we're talking about people who were raised in disordered or chaotic social environments, maybe with parents or caretakers who just weren't very well equipped to parent competently or to protect their own children from different kinds of harms. And so we also know that the 10 items in the ACE scale that really only captures, again, a little bit of a piece of what we know is the vast array of different traumatic experiences that people can experience. And so we know that there are certain types of adversities that are more likely to occur in disadvantaged communities. And then we know there are also traumatic, unexpected events that can happen to anyone and also do leave lasting impacts emotionally and psychologically. So a traumatic event really can be any unexpected event that makes us feel threatened in some way, physically or psychologically. And when kids are exposed to trauma over and over again, it compounds the effects of that. So it is the chronicity, accumulation, and multiplicity of different kinds of childhood traumas that raise the risk for different kinds of health, mental health, and behavioral problems across the lifespan. So that's what I became interested in learning more about. And the CDC has now published, there have been over 100 studies published from that original data and others who have replicated and collected other data. There still exists, right now there's an ongoing program called the BRFIS program, the Behavioral Risk Factor Surveillance System, where state State health departments collect data through phone surveys. So we're learning more about this, but lots and lots of studies. And what's very clear is that there is a dose-response relationship between early adversity and adult outcomes, psychosocial, behavioral, medical, and mental health outcomes. In other words, the higher your ACE score, the more likely you are across the board to have a range of different kinds of problems growing into adulthood. So I became interested in learning more about these issues in the population I serve, which are people who have been convicted for sexual offenses. And so we collected data from about 700 people in sex offender treatment across the country. And what we did was, this was all self-report, but we gave them the actual original ACE survey and asked them to tell us about their childhood experiences. And as you can see, we then compared what the prevalence rates were of the offenders with the rates to the males in the original CDC sample. And you can see that the rates were all higher, in some cases much higher, for the offenders than in the general male population. And then we calculated odds ratios, which basically is just a fancy way of saying, for example, that people convicted of sexual offending are 3 times more likely to have experienced child sexual abuse than males in the general population. This is the distribution of ACE scores for the male offenders that we collected data from. And what was significant to me here is, remember I told you that in the CDC study, about a third of people said that they had no adverse experiences, and less than 16% of the male sex offenders endorsed 0 experiences. And then when you look at the rate of 4+, almost 46% of the male sex offenders endorsed 4 or more childhood adversities, compared with about 9% of the males in the original CDC sample. So, prevalence, the prevalence rates are very different. This is a second sample, so we kind of try to replicate this with a different sample. So now we have data from over 1,000 men in sex offender treatment across 10 or 12 states in the U.S. And the numbers are a little bit different, but again, we see about 16% endorsed 0 and 38% endorsed a score of 4 or more. So what we know is that samples of people who have been convicted of sexual crimes are 4 to 5 times more likely than males in the general population to have an ACE score of 4 or more. This is the distribution of ACE scores for female sex offenders. We had about 47 of them in our sample, and 41% of them had a score of 4 or more, compared to 15% of females in the original CDC sample. So, I think that this is important for us to know about. And since then, we've published, we've had many publications with different partners. Dr. Melissa Grady from Catholic University is here somewhere in the audience, one of my collaborators on this project. Kelly Sosha, some other people who I've published with. But we asked a lot of different questions, but just to kind of summarize some of the things we found is that higher ACE scores were associated with versatility in criminal behavior. So the higher your ACE score, the more likely they were to have different types of arrests, not just sexual arrests, but other types of criminal behavior too. Higher ACE scores were associated with persistence. The higher your ACE score, the higher the number of general arrests they had had. And then we had different measures of sexual deviance or paraphilic interests, measures of sexual violence like using a weapon or causing an injury to a victim in the commission of a sex crime, and substance abuse behaviors. And all of these things were clearly associated with higher ACE scores. We also tried to, and we're still trying to kind of think about, are there specific ACE experiences that factor together and contribute in some unique way to criminal sexual behavior and also general criminal behavior. And this would be a much longer presentation for a different day. Here are just some of the items the correlations that stood out to us. But I think when we try and think about what this means and how it translates into sexually abusive behavior, we're kind of thinking about how that early adversity then leads to distorted boundaries and self-regulation problems, and how chaotic families contribute by, when kids grow up in families where there aren't real good examples of law-abiding and healthy relationships, then that can pave the way for a lot of problems, including a life of crime. This is a different study that is with my colleagues from the Florida Department of Juvenile Justice. And this is really cool because I don't want to traumatize you guys too much, but when you're talking about sample sizes, bigger is better, right? And so they've been collecting data for like 15 years from every single youth who goes through the Florida DJJ system. And so they now have a database of like over 80,000 kids. And so this is really, really informative to us to understand youth delinquency and behavior problems. So anyway, this is a look at the distribution of ACE scores of Florida DJJ kids. So again, what do we see? You look over there on the right, score 4 or more. 50% of the kids in our system, in our delinquency system, have ACE scores of 4 or more. These are the 6,500 plus kids who had been adjudicated for some sort of sexual crime in our Florida DJJ system. And here we compared the juveniles who had committed sex offenses with juveniles who had committed non-sex offenses, and we also then compared their adversity rates with the adult sex offenders from my sample and also with the general CDC numbers. And so again, there over on the right, you can see that the kids with the JSO kids, these are males, 32% of them had ACE scores of 4 or more, and very, very few had ACE scores of 0. These are the females. So same kinds of trends. And so I think we're better able now to see some of the big picture of this and think about what it means. This is, again, the DJJ youth, all of them, not just the ones convicted of sexual crimes. And you can see the prevalence rates of all of the different ACE items. So these are kids who have come from very troubled families. Interestingly, the highest is that over 80% of them grew up in homes with some sort of domestic or family violence in their homes. So that's important for us to know as preventionists. So what happens when kids grow up in environments where they are constantly having to scan the environment for danger? Well, we all know about fight, flight, or freeze, and we can all imagine, I'm sure we've all had experiences where you get startled or scared or something happens. So when kids are living in environments where this is what's going on for them day in and day out, it actually changes the architecture of the brain. It changes the way the brain functions. And there's a lot of neuroscientific data and now with imaging to help us understand this. Again, like Elizabeth said earlier, this is not a fluke. This is a thing, and it's a real thing. And so when kids are constantly in survival mode of fight, flight, or freeze, and those stress hormones are constantly surging through their bodies, a number of different things happen. One is they become conditioned socially, psychologically, behaviorally to always be scanning the environment and ready to respond to the next threat in order to stay safe. But the other thing that happens neurobiologically, which I'm less of an expert in, but my understanding is that when that area of the brain is getting a lot of rehearsal and practice and overdeveloping to help keep kids safe in their environment, other areas of the brain, like the frontal lobe, cognitive processing, self-regulation, decision-making, judgment, reasoning, all of that stuff that we really need to succeed is underdeveloped and under-rehearsed. And so it's maybe not surprising then that early adversity affects people's lives in very profound and very specific ways. One of which is that early adversity impacts the way we think about ourselves and others and the world. So it affects the core schema, the cognitive schema that a person has about the world. And this kind of translates into expectations of others, the way you interpret the events that are going on around you, and how you attach meaning to your existence. And for those of you who are clinical people here in the room, we know in the DSM, personality disorders are defined as pervasive, enduring patterns of thinking, feeling, and behavior. And that's really, what we're talking about. Early adversity shapes the personality into a more unhealthy way of being. We know that early adversity impacts behavior, and so as we talked about, you kind of have these neurobiological insults or changes. You may have kids who have disrupted attachments with their caregivers. You may have a home where there's an absence of healthy role modeling, and then on the flip side of that, an overabundance of maladaptive skill rehearsal. And you end up with kids who grow up into adulthood with a lot of skills deficits in terms of being able to have healthy relationships and also to regulate their own behavior and emotions. So how does this translate into sexual assault? And again, this is not an excuse for anybody's victimizing behavior, but I think that we have to understand how these behaviors begin to develop through the lens of early trauma, childhood trauma. So, there are a lot of different factors. They're different for everybody, but early adversity, especially when it's chronic and continuous, is going to mean that people have distorted boundaries, they have distorted skills, they may have been conditioned to act in certain ways, they may be reenacting things that have been done with them, they may not feel a sense of self-efficacy, so in some cases they may turn to children who seem to be less threatening to have relationships with. They may have been raised in homes or communities where the way you get what you need is through violence and abuse of power. All of these different things, and of course it's a unique constellation of factors for everybody. But in general, if I were going to sum it up in a sentence, I would say that kids growing up in chronically adverse conditions who then later in life sexually offend are somehow using sex and sexual assault as the vehicle to meet psychological, emotional, and social needs. And that doesn't excuse it, but we have to understand it because it's really about adaptation. So you think about from an evolutionary model, adaptation is about characteristics that evolve in order to help an individual or a species adjust to the demands of the environment. And that's what happens to kids. So none of us get out unscathed, but on the spectrum of family function to dysfunction, people who were raised in a relatively more healthy environment have skills that are more adaptive to the rest of the world when they grow up. And kids who are growing up in very dysfunctional environments develop well-rehearsed skills that are much less applicable in the real world. And so, and when behaviors become maladaptive, when they help in that moment in terms of survival, but they hurt people in terms of being able to achieve their lifelong goals. And we know that there are kids who have suffered terrible abuse and maltreatment and don't grow up to abuse others. So, we're still trying to understand the factors of the who and why, I think. But we need to continue to try and understand it better. And this means that if we're going to move toward a more efficient prevention model, we really need to have a paradigm shift in our communities and in our policies. And just the fact that we're all sitting here in this room together is a step in doing this. And as one of the speakers said earlier, we need to find out how to translate this also to policymakers and stakeholders and unlikely allies. So here are a couple thoughts. One is that SAMHSA has been talking for probably 10 or 12 years about trauma-informed care and a trauma-informed approach. And I would encourage you, if you haven't already, to go on the website. Just Google SAMHSA Trauma-Informed Care, and you'll get to the website, and there are dozens of publications and resources and really great information that helps all of us across every problem or population we work with, or any different kind of social service setting or private practice or hospital or wherever, to try and think about how we can view problems through the lens of trauma. And we do this in our relationships with the people we serve, and then also from the top down and the bottom up, you know, in the boardroom, in the policy making capitals of our states, and in the federal government. There are some interesting trauma-informed initiatives going on in schools and in courthouses, like with therapeutic courts or specialty courts. So this isn't just about therapists or social workers. You don't have to be a therapist to be therapeutic. It's about seeing things differently, because we know that the best predictor of resilience for kids and for adults is to have somebody who believes in you and gives you guidance and support. And so obviously the earlier we can do that with children, the better. But even for those of us who work with very, very troubled adults, I don't think it's ever too late. And for my clients who come to see me, my office may be, for many of them, the safest place they've ever been and the most intimate relationship they've ever had. And I think that's a good thing. I think that corrective relationships are really what we need to be talking about, because people need to feel connected to others. And when they don't, they turn to self-destructive or other harmful kinds of behaviors. And so we really do have to move in our society in a direction of being more purposeful and helping youngsters and families create opportunities for meaningful attachments and pursuits and self-efficacy. So I know I'm running out of time. You're all hungry. So clearly not every abused child grows up to be an abuser, but we do know that abused and neglected children are more likely than non-abused youngsters to have problems, including engaging in criminal behavior. And we know that this is even more pronounced in disadvantaged and minority communities. And so we really need to flip that prevention pyramid so we can invest in primary prevention programs for at-risk families and communities. Because every dollar that we spend on incarceration and sex offender registries and foster care placements is a dollar that's not spent on victim services and prevention programs for families and primary prevention. Now, we know that. We're kind of preaching to the choir. So here's what the real public health model looks like. You know this. But we really have to start at that primary level of addressing poverty and not cutting the safety net that exists, and really shifting our paradigm about the way we think about marginalized people in our communities. We need to change the cultural messaging that we do around respect and consent and gender roles. From a secondary prevention point of view, as we're moving toward creating more trauma-informed institutions and services, I think that it does take a village. And so there are kids who grow up in families where they're not getting what they need. And so when they go to school or when they interact with other adults around them, that's where the resilience building takes place and the prevention takes place. And we should really be investing a much smaller portion of our resources into these tertiary kinds of programs. But when we do, we should be thinking not just about incarceration, but about treatment and support and accountability and reentry services, so that people who have committed crimes can reintegrate into the society with supports and be more likely to live a law-abiding life. So, thank you. I know that I didn't have to get you too far out of the box, but I think we're all on the same page, and we know that prevention is possible. So we just have to figure out how to spread that word and get other people to listen to us. Thank you.